we have to finish dermat. I hope you guys are all on track. MCQs everybody's been doing. Yeah, all right, wonderful. Just one thing I wanted to clarify, guys. Wait, huh? Okay, so yeah, you just click on the pinned link and you'll be redirected to the group. Those of you who have not yet joined the group, you'll find the latest pinned message is the PDF. Okay, ठीक है? Zara's viral is also better, but it's still persisting. So that's why I was a bit late because she was not letting me go. So yeah, so that is how I have come. Okay. Anyways, can you send group name? It's a private group. Name se nahi milega. It's a private group. So you'll have to click on the pinned link. Yeah. Okay. Yeah. So just one thing I wanted to say about yesterday. Remember we did one MCQ about erythrodermic psoriasis, what is the drug of choice? So वो ना दो जगह पे अलग अलग दिया. I was just, because I also got confused yesterday. I was just looking it up. So I mean it's given as methotrexate in some places, given as steroids in some places, but methotrexate is the better answer. ठीक है, steroids नहीं. हाँ. So that's why I wanted to clarify that if they give you कि psoriasis vulgaris है, which is extensive. Technically speaking, extensive psoriasis vulgaris is also erythroderma because the entire body is involved. But for MCQ purpose, when they give you extensive psoriasis vulgaris, what is the treatment of choice? Then you're going to give steroids, right? But when they give you that, if there is erythrodermic psoriasis, naam mein hi agar erythrodermic psoriasis aa gaya, then mark methotrexate more than steroids, right? Is that okay? So this is one clarification that I wanted, that erythrodermic doesn't actually translate to extensive psoriasis vulgaris. Okay. Yeah. Collagen dermis ratio 8:1, 4:1. Yeah, but it's not 3:1, है ना? मतलब वो एक MCQ था, that वो तो कल ही पता था कि it's a controversy, अलग अलग दिया हुआ है, somewhere it's 4:1, 8 or it's not 3:1. Just उतना याद रख लो, because that was an MCQ question. Okay, so it's definitely more than 3:1 is what we have established. Fine. So yeah, I hope this is clarified. Anything else that you have, वो बता देना. Actinic lichen planus is any lichen planus which occurs in any sun exposed area. तो अगर face पे आ रहा है, हाथ पे आ रहा है, that is your actinic lichen planus. Okay, so morphology wise lichen planus है, but it's because of sun exposure. Okay, acetretin washout period में तो कोई doubt नहीं है. It is 3 years only. तो वो तो Google search कर लो, you'll get it. You will find a line in Google कि it takes up to 3 years to be washed out completely. ठीक है? Melanocyte and melanosome same nahi hai na. Melanocytes are going to produce melanosomes which will be transmitted to all the keratinocytes. So kaise pigment ja raha is through melanosomes, and melanocyte is the cell which is only one. Melanosomes will be spread everywhere. Okay. So now do these topics from notes and MCQs? Yes, absolutely. Like I have explained how to take these classes. So today we'll be done with dermat, right? So from my end, I have done my job from dermat. Almost everything is covered. Derma is one short subjects. I will try ki pure ho jaye, right? So derma is completely gonna be covered from my end. What you have to do is complete the question bank, complete the notes, and make sure everything is, no blanks are left. जैसे मैं बहुत MCQs नहीं, I mean बहुत treatment नहीं बता रही. So make sure you are just seeing that whatever are the fill in the blanks which have been asked in the question bank. आपका बस उतना काम है, बाकी keep revising whatever is this. Okay, questions in derm, see variable, but 5 to 6 तो expect करोगे, है ना? A small subject 5 to 6, but direct questions, very this thing scoreable. ठीक है, शुरू करते हैं. Lots to do then. All your other physio वाले doubts I'll ask on the group, I'll answer. Okay, right. So this is about that. Okay, so now we begin with the most important. So those of you who are appearing for INICT, invariably you get questions from Vazicobullus. In fact, even FMG aspirants. Important. So those of you who are appearing for INICT, invariably you get questions from Vazicobullus. In fact, even FMG aspirants, this is one topic which both of them love, FMG and INICT. So this is very important. NEET also you get questions, but thode less. But INICT is sure. You always get questions from this. So this is what we are going to be doing. So when we deal with Vazicobullus, from yesterday's discussion, can you tell me what is the layer of epidermis which is going to be involved here if it's an epidermal thing? Huh? Yes, अगर epidermal है तो spinosum, right? Remember we had desmogleins, desmosomes which were connecting those cells here. So that is going to be defective in the epidermal region. Then we can have dermoepidermal region. So we are going to be studying some bit of anatomy of dermoepidermal junction, and we are going to be dealing with spinosum layer in the epidermis, right? So that is where you had predominantly desmosomes. So now when we are dealing with vesicobullous disease, we basically have two types of lesions. We can either have intraepidermal split, or I can have dermoepidermal junction split, right? When we deal with epidermal split, now I have two kinds of desmoglein. From the top we have desmoglein 1, uske niche we have desmoglein 3. 1 is upar, 3 is niche, right? So when we have desmoglein 1, we are, whenever this is defective, right, or whenever there is problem with this, we are going to have a subcorneal split. So where would this desmoglein be lying if there is a subcorneal split? Cornea के नीचे कौन सा layer है? Legs, right? L is not present everywhere. So this is predominantly in the stratum granulosum, right? So can I say that this is predominantly in the granular layer? That is why we are having subcorneal split, yeah? And the desmoglein 3 is gonna have supra-basal split. So where do you think this is gonna be? So supra-basal split means it's going to be spinosum, right? Legs, and then we have basal. So this desmoglein, as we have discussed, is predominantly going to be in the spinosum layer. So this is from the top. Which of these is going to be present in the mucosal membrane, in the oral mucosa? It is desmoglein 3. So can I say that only in this disease I'm going to have mucosal involvement, not in this disease? Yeah. So वो एक difference हो गया. Now, anytime we have epidermal lesions, we call it pemphigus. जो ऊपर वाले lesions है, rarer. What is the prototype pemphigus where you have desmoglein 1 involvement? PF, pemphigus foliaceus. There is one more variant of pemphigus foliaceus which mimics SLE. So उसका नाम क्या रख दिया? SLE पे ही हमने नाम रख दिया एरिदोमटोसस, ठीक है, SLE जैसा ही. So these are your desmoglein 1. So दोनों के लिए we will have a subcorneal split, or the problem is in the granular layer. So just remember subcorneal split, desmoglein 1 on the top. नीचे जाएंगे desmoglein 3, the most common prototype pemphigus, suprabasal split. It is P. vulgaris. And we know anytime something is most common, I'm going to use the term vulgaris. So this is P. vulgaris, and this is also going to have mucosal involvement. इसका वेरिएंट कौन है? V से ही P. vegetans. So इसका एक और वेरिएंट है P. vegetans. So both of them will have similar behavior. Got it? So this is your epidermal. When we go to subepidermal lesions, dermoepidermal junction, the prototype is bullous pemphigoid, and then I will have other things like linear IgA disease. I will have dermatitis herpetiformis, pemphigus gestationalis, right? So all of these things I'm going to have, but the prototype is going to remain BP. Right. So this is about a broad classification. Now, are we ready to see images and study all of them in detail? I'll talk about all of that. DH क्या है सब बताऊंगी. Okay. So the difference, again, one more difference, ये सब कुछ बताऊंगी. The difference is, one more difference is when I say कि ये epidermal है. Do you agree that their roof of the vesicle and the bulla is not going to be very strong? So it will rupture, right? So these are going to be flaccid bullae, whereas this has the complete epidermis on the top. So this is going to have tense bulla, जिसका membrane will not rupture, isn't it? So the basic difference, tense bulla, flaccid bulla. Now when it is desmoglein 1, just a subcorneal split, do you agree that it's going to be almost always just crusting that I'm going to see? I'm not even going to see flaccid bullae. Bulle bhi nahi dikhenge. I'm only going to see crust, because this is what? This is the prototype of subcorneal split, right? So both of these have desmoglein 1. So do you agree that इनके ऊपर का membrane is so thin that I'm only gonna see erosions and I'm gonna see crusting? I will almost never see bulla only. So what is this prototype here of subcorneal split desmoglein 1? This is P. foliaceus. And we said mimic of SLE or variant of SLE, right? So do you see this again? You have the involvement of your malar areas, right? So just like that, this is also pemphigus erythematosus. All right, is this clear? So these are the two rare ones which nobody really has asked so far, but just for understanding, we have done it first because ये सबसे ऊपर है. So you remember कि this is subcorneal split, this is desmoglein 1. इसके नीचे आएंगे, this is what is important. So again you see that bulla कैसा है, this has come as an image based question in FMG. This is what, yeah, this is flaccid bulla, isn't it? So this is flaccid bulla which is going to rupture. ठीक है, so flaccid bulla हो गया. Can you see how all of them have ruptured here in the trunk? And what else are you seeing? We are seeing the presence of oral involvement, mucosal involvement, isn't it? So इसमें कौन सा desmoglein होगा? So this is desmoglein 3. What should be the level of split? Level of split is, yes, very nice, supra basal split, right? So supra basal split means the problem is in spinous layer, isn't it? So what is the diagnosis here? This is our most common pemphigus vulgaris. This is what we need to know. बताऊंगी अभी, ठीक है? As I said yesterday, just hold on with doubts. सब cover हो जाएगा. अगर cover नहीं हुआ end में, है ना? Bulla has fluid inside. Why is it like that? Because of, I mean, it's a split, right? Fluid is accumulating in vasicobullous region. Okay, so this is pemphigus vulgaris. Why this ruptures? Because again, there is a thin layer, है ना? Epidermal है, so they will rupture, like I said earlier. Okay, so this is pemphigus vulgaris. Then, what is the variant of pemphigus vulgaris? The pemphigus vulgaris variant is pemphigus vegetans. है ना? सारे डाउट सेव करके रखो, otherwise they'll be lost in the comments. आंसर करो comments में, डाउट सेव करके रखो, ask me in the end. P vegetans. So here you are gonna have warty lesions. Remember, verse vegetans, verse warty. This is kind of a different type of pemphigus. So warty lesions, and this is one named sign. Very nice. I'm very impressed that you know it. This is Prem Lata sign, right? You just need to know this because it's an Indian. Otherwise, this has never been tested. Nobody will teach you this also. This is Prem Lata sign. This is also seen in pemphigus vegetans. है ना? तो बस इतना सा याद रख लो कि Prem Lata, P, vegetans, warty, everything is sticking together here. So when you have this verrucous looking tongue, this is P vegetans. Okay, so that is all you need to remember. Not very important, just for an extra edge for INICT. This is there. Okay, right. So now in all of, is this Prem Lata? This lady? No, but this sign is Prem Lata. Okay, lady, I don't know. Right. So now in pemphigus, we will have three things. So in pemphigus, when we do a Zank smear, what will happen in Zank smear? Yesterday we saw na, that all of these are cells are connected by desmosomes, calcium ATPase. When that disappears, all of the cells are going to show you this acanthocytes, right? So this we have already discussed in the first table only. So these are all your acanthocytes, which are your cells which have detached from one another in the Zank smear. Very, very important image. So many times this has been tested. When you do direct immunofluorescence, what are you going to see? Again, because this is an autoimmune disease, I'm going to have IgG and C3 complement deposition in what kind of a pattern? In a fishnet pattern, right? Because it is intraepidermal. There's intraepidermal DSG3 against antibodies hai, complement hai, which is getting activated. So this is that very typical fishnet appearance. When you take a biopsy, histopath, what are you going to see? We'll see a split. Now, always you want to find out the level of the split. So you can see that this is the basal layer, right? So now from yesterday, can you guys understand this? So here we have the suprabasal split. Why is the cell blue? Tell me, what is the stain you use for Zank smear? All of these things you should tell me better. So this is suprabasal split, right? So this is the row of tombstone appearance that you are seeing. Correct. So this is row of tombstone. Yeah, in all pemphigus you will see this. Yeah, because of the gene stain, right? So suprabasal split, imagine as a radiologist I am teaching you. So this is suprabasal and this is row of tombstone. ठीक है, तो ये हो गया हमारे pemphigus वाले answers. Understood everybody? So acanthocytes, DIF and suprabasal split, which is row of tombstone. Now we have one more pemphigus. We're still in the epidermis. So what do you have? Here you have polymorphic skin, mucosa, multiple kinds of erosions and everything. But the important part is there's underlying neoplasia. So what is this? This is a paraneoplastic pemphigus. Yesterday I told you three kinds of desmosome proteins. Desmoglein, we have already done. Desmoplakin, desmocolin. So this is what? P for paraneoplastic pemphigus, P for desmoplakin. So this is gonna be against desmoplakin, right? So this is the antigen which is involved here, desmoplakin. So we'll see these autoantibodies, acantholysis bhi milega. Again, you will see fishnet pattern, right? So the most important thing is there's going to be underlying neoplasia, and correct, the most common neoplasia here is non-Hodgkin's lymphoma. All right, that is what you need to remember. That is going to be most common. That is all you need to know about paraneoplastic. Very rare, again, you see pustules, right? You see pustules within the vesicobullous chapter. So what do you see this? There is this fluid pus level. Pus bhi hai and fluid bhi hai. So this is called as the hypopion sign. Remember hypopion from ophthalm? So just like that, pus fluid level ke karan we are saying hypopion. What what kind of ganda imagination? This is hypopion sign. Okay, so that's a subcorneal pustular dermatosis, right? So this is subcorneal pustular dermatosis. And now what is the antigen, target antigen? The third one, desmocolin. Again, this is not very important. Most people will not teach you this. Just remember hypopion sign, subcorneal pustular dermatosis. Okay, so this is about hypopion sign. Okay, two very, very important diseases which have been tested in INICT previously. So along with desmosomes, you also have calcium ATPase, right, which is connecting all of these cells in the spinous layer. Calcium ATPase has two kinds of variant. One is 2A2, another one is 2C1. So C से याद रखो Haley's comet. So the disease on the right is Haley, right? Did you see how I did this for right? Because every time I have to do this, I'm spatially challenged. So I have to do this is right, this is left, like a child I have to do, because of radiology, everything is ulta. So I do like a child, this is right, this is left. So this on the right is Haley, and this on the left is Darier's disease, right? So yeah, in the, you know how people who do not know English well or Hindi well, like you think in one language and you talk in another language, right? So first you have to think and then it comes in your mouth. Same happens with my sides. First I have to think and then I have to speak. It's not an instinct right left for me. Everything has been screwed up because of radiology. Anyways, so this is Haley, and this is Darier's disease, right? So Haley, let's talk about Darier's first. So in Darier's, I'm good that there are more people who are challenged like me. That just makes me feel better, and I'm sure it makes you feel better also. So Darier's disease, you have all of these grainy lesions. So इनको क्या नाम देते हैं? What do we call them crop grains, yeah, crop ronds, right? So that is what we call them. And very typical nail changes in both of them, in fact. So here we are going to see a V split, right? D and V are rhyming, no? DV. So remember D and V split will be seen in Darier's disease. It's not with H, right? So DV go together. So V split in Darier's disease. On the other hand, Haley, what will you see? We'll see the intertriginous area. Has this played a very important role in dermat, right? Where all have we seen this kind of intertriginous involvement, axillary involvement? Just name a few diseases जो हमने कल से पढ़ा है. Yes, Fox Fordyce disease. If you see spots where the glands are blocked. What else? Candida can have reddish involvement, right? What else? Acanthosis nigricans. Acanthosis nigricans will have black, velvety lesion. If it's an infection, erythrasma, right? So erythrasma, what will you do? You will do Wood's lamp. You will see coral red appearance. तो उससे पता चल जाएगा. And Fox Fordyce gets complicated and forms these tracts, sinuses, ganda stuff. What is that? That is hidradenitis suppurata, right? So now one more thing gets added here, which is Haley. Can you remember this entire picture? Yes, scrofuloderma also. If you have axillary lymph nodes, usually it will be cervical lymph nodes which will be given, है ना? Axillary thoda rarely. Okay, so this is about this. Did you develop this pattern based approach? ठीक है. All of wow, all of these are for axillary involvement, right? So anytime axillary or intertriginous involvement, it is this, right? Hidradenitis suppurata kal pada na, complication of Fox Fordyce, where you will have a lot of tracts and sinuses and fistula. Okay, right? So this is Haley. The characteristic nail pattern is going to be what? You are going to have these longitudinal lines. So intertrigo also. Intertrigo is a general term for candida only. Candida ka naam hai. So longitudinal lines, basically you will see, and anytime you have lines, does it remind you of walls? Yeah, so line से wall याद रखो, and this gives you a typical appearance of dilapidated wall. ठीक है, dilapidated wall means a destroyed brick wall. ठीक है, so you can remember dilapidated brick wall here. So all of these are changes of Haley. Okay guys, understood? So these are two diseases which can be tested in INICT for you. Okay, right. So this was about our epidermal things. ठीक है, अब हम जा रहे हैं टेंस बुल्ला. डू यू सी हाउ दीज बुल्ले आर सो टेंस, डिफरेंट फ्रॉम पेम्फिगस? समझ में आ रहा है? पेम्फिगस में फ्लैसिड थे ना, थिन रूफ, बट नाउ यू हैव द एंटायर डर्मिस उसके ऊपर. सो कैल्शियम एटीपीएस वाला पॉइंट बस वो जीन्स है जिसके अगेंस्ट यू हैव विच इज डिफेक्टिव हियर. सो दिस इज 2A2 जीन, दिस इज 2C1 जीन, दिस जस्ट द जीन विच इज डिफेक्टिव, राइट? सो दीज आर योर टेंस बुल्ले दैट यू हैव here. ठीक है, so टेंस बुल्ला देंगे, very very important. Plus what else will they give you? That the patient also has a lot of pruritus, right? So pruritus hoga. Why pruritus? What will that be explained by pathologically? Correct. When you do a pathological specimen, split to milega, but साथ में you'll also see eosinophils, which explains the pruritus, which will be a very important feature. And these patients will be older, right? So they'll give you elderly male patient who's having pruritus and tense bullous lesions. Your diagnosis is always going to be what? Very very important. Bullous pemphigoid, right? So multiple times asked diagnostic, simple straight liner. हम तो इतना high level पढ़ रहे हैं that diagnosis तो I'm sure you guys will make only. Okay, so this is bullous pemphigoid. What kind of a split you will see? Dermoepidermal junction, right? Can you see how epidermis and dermis के बीच में there is a split, subepidermal or dermoepidermal junction पे there is gonna be split. When you look at the DIF here, what are you going to see? Again, I will have IgG3 deposition, but how is this? Now it's at the junction, right? So this is not going to be fishnet, but this is going to be linear. Okay, DIF only. DIF is always better than Zank smear because Zank smear is not specific for anything. Okay, so this is going to be a linear along the basement membrane zone. Okay, so this is about bullous pemphigoid. Anybody has any doubt here? Very very important. Okay, don't get this wrong. Now few variants. Now instead, let's have a look at this only first. So here also it is linear, but it is not against IgG. इसमें Zank में कुछ नहीं मिलेगा. No, it is also linear, but what is the antibody which will be deposited? IgA. So इसी पे हमने नाम रख दिया that because of linear IgA deposition, so we thought दिमाग क्यों लगाना, let's just call it linear IgA disease. But then we thought नहीं, थोड़ा थोड़ा दिमाग लगाते हैं. What if this disease occurs in a child? अगर adult में बन रहा था, we called it this, but when it was occurring in a child, we called it something different. We called it chronic bullous disease of childhood. उसमें भी ज्यादा दिमाग नहीं लगाया. Chronic bullous disease of childhood, है ना? तो ये भी ठीक ठाक ही दिमाग लगाया. So two diseases, so same spectrum, same immunofluorescence, everything, but the pattern will be different. So when you see it in a child, how is the pattern? It is perioral perigenital, है ना? You are seeing that the lesions are distributed in a perioral perigenital fashion, whereas in an adults they are all arranged randomly. So these can be seen in the extremities, in the trunks, and the appearance, if you see, is like a string of pearls. So this has been given the name of string of pearls sign. Okay, yeah, so here you'll see crusting, bulla, everything. Yeah, we'll get to that, Anil, just hold on. I जाएंगे वहां पे. Okay, yeah, here because there's a lot of itching also. Anytime you have IgA deposition, you'll have a lot of pruritus again. So a lot of these bullae will actually rupture, and that is why this name is string of pearls appearance. Okay, is this clear? Both of them are the same disease spectrum, adults versus child. Again, let's continue with Ig only. And one more factor, whenever we have IgA, what is going to be the treatment? जब भी IgA is getting deposited, the treatment is going to remain common, which is going to be Dapsone. So next disease also, we have IgA deposition, but now what is the pattern? Is it linear? No, this is along the papillary tip, right? So this is how, this is granular. So when you have granular IgA deposition, and we had seen this yesterday, when you have neutrophilic microabscesses, but the microabscesses are at papillary tip. Remember, neutrophilic microabscesses, what were the other two abscesses, guys? Other two abscesses were in psoriasis, right? So we had Munro's microabscess and Kojock's pustules. Both of them were neutrophilic. Pottier's was lymphocytic. It was not neutrophilic, है ना? So this is your IgA papillary tip microabscess. इसको हमने एक नाम भी दिया है. This is also called as a picket fence appearance. So this is also called as picket offense sign. Okay, so what is this disease that we are talking about now, where you have this granular IgA deposition? There's going to be a lot of itching here. Correct. So इसीलिए हमने नाम दे दिया dermatitis, because so much itching. Dermatitis herpetiformis. This is associated with what? What do you want to rule out? I'm going to rule out celiac disease in this patient, right? So celiac disease is associated with this, which needs to be ruled out. So you will see that extensor surfaces are involved, trunk is involved here, and celiac may, you all know that's because of TTG, right? So you will have, this is the most sensitive enzyme that you want to rule out, tissue transglutaminase enzyme, that you want to basically screen for. And if found positive, what do you want to avoid? If I ask you, what is the treatment of choice of dermatitis herpetiformis? Remember, it is not Dapsone. Dapsone is the drug of choice, but the treatment of choice is dietary alteration, where you avoid brow. Remember this. So we want to avoid brow here. No, here no eosinophils, here only neutrophils. Okay. So क्या क्या brow में आता है? Barley, rye, oat, and wheat. So these are the four things with gluten that we want to avoid, right? So this is what we are. So mostly these people are on rice, है ना? तो rice based diet पे होते हैं mostly, and this is the mainstay. And apart from that, drug of choice puche, to again, because it's IgA, it will remain Dapsone. Okay, so this is about dermatitis herpetiformis. What do you want to follow these patients up for? Celiac disease patients are at risk for EATL. Remember, what is EATL? Enteropathic associated T cell lymphoma. So predominantly T cell lymphoma develop kar sakte of the bowel, which we want to screen for. Okay, so this is what we want. Next, does this female look pregnant? Yes, she is pregnant. So अगर pregnancy में हो जाए आपको, फिर क्या है? Yeah, HLA DQ2 and DQ8. That's also you can remember HLA DQ2, DQ8 here. ठीक है. So this is what? This is pemphigus gestationalis, right? So pemphigus to hai, but gestationalis. So that is the only thing that you want to remember here. Does it have a good prognosis or a bad prognosis? You will ask me, ma'am, for baby or for mother? So for baby, remember, this has high fetal mortality. So not good prognosis for fetus, 30% high fetal mortality, correct? But for mother, mother ke liye good, because this will resolve. As soon as pregnancy is over, this will resolve. So for mummy, it is good. But for baby, it is not good, right? High mortality. What will you see in immunofluorescence? Same like bullous pemphigoid. So you will see IgG-C3 deposition along the basement membrane, right? So this is a linear deposition. Okay. Yes, Dapsone for recurrence of DH. Yeah. Apart from that, what is the target antigen in bullous pemphigoid? It is BP antigen only. Which antigen? BP antigen 2 or BP antigen 1? Both can be there, 2 more than 1, right? So 2 more than 1 is what you can remember here. हाँ, इनके नाम भी पूछ सकते हैं. So this is 180 and this is 230. Again, see how it is always ulta for us. 2 is not starting with 2 and 1 is not starting with 1. So it's BP antigen 2 is 180 and 1 is 230. So just remember it's ulta. Okay. So this is about all your gestational diseases. Now let's talk a bit about the dermo-epidermal junction ka anatomy. Remember 3 things. Do you remember K5 by 14 yesterday, which was there in the basal layer? Yeah. So this is the first thing. Apart from that, उसके नीचे जाओगे तो you will have your BP antigens 180, 230. You will have laminin, and सबसे नीचे you have type 7 collagen. So these are the structures I want you to remember. We have K515, we have BP antigen, we have laminin, and we have type 7 collagen सबसे नीचे. Now, we can have 2 types of epidermolysis bullosa. For a diagnosis of epidermolysis bullosa, what will be the typical history? When are these bullous diseases happening? On trauma, right? So this is a type of mechanobullous disorder. So this is trauma induced blisters or trauma induced bullous diseases, right? So that is the first thing. Now this can be congenital, this can be acquired. Congenital is of 3 types. What 3 types? EB simplex if K514 is gone, junctionalis if laminin is not there, dystrophic if type 7 collagen is not there, right? So these are the 3 things which are your types of congenital EB, where these are absent. On the other hand, EB acquisita means acquired is when you have antibodies against type 7 collagen. Understood? Two types, EB congenita, where ye teen are not there only. EB acquisita, when these have antibodies, type 7. Okay, so now again we will have similar patterns. So when we talk about EB acquisita and I do an immunofluorescence, do you agree type 7 collagen layer pe we're going to have this linear sort of a pattern? So how do I distinguish this from bullous pemphigoid? So for this, we do a salt split DIF. So salt split DIF will basically produce two layers. So here we have a layer where you have basement membrane zone, that is your lamina lucida. Okay, so that is your lamina lucida where it creates a split. So now tell me, if we are dealing with a case of BP, bullous pemphigoid, will I see the immunofluorescence above it because BP antigen is here? Yeah, so I will see that this white line is on the roof. Are you understanding? I will see that the white line is here along the roof in bullous pemphigoid. But because collagen 7 is niche, I will see that in EB acquisita, this line is niche, like in this case. So just one point for INICT, that when you see floor pe, it is EB acquisita. If you see ऊपर, it is BP bullous pemphigoid. Yeah, इसका trick ये है BP bullous pemphigoid के अलावा BP, we drink BP on the roof. ऐसा करके याद रखना है. So BP is on the roof, whereas this is in the floor. Okay, not understood तो न्यूमोनिक याद रखो कि BP कहाँ पे आएगा? Roof पे. Floor पे आएगा EB acquisita. Okay, so basically what we are doing is, अपन ने in this only, whenever you get a linear pattern, I have created a salt split. If you see immunofluorescence on the roof, the diagnosis is going to be bullous pemphigoid. When you see immunofluorescence on the floor, the diagnosis is going to be EB acquisita. Okay, that is what you have to remember. INICT will ask, उसके ऊपर question नहीं आएंगे. Okay, right. So very quickly, just one summary. P foliaceous, first of all, what is the desmoglein which is absent? Sabse upar. DSG1. This is DSG3. So how is the split? Sabse upar, sub corneal split. And iske niche kya hai? We have supra basal split. Right? Dono mein hi DIF is going to show you what? A fish net pattern. Darius or Haley, maybe we have intraepidermal split only. DIF doesn't show you anything, but you can have dilapidated brick wall appearance in Haley, and you will have crop grains, crop rounds in Darius, right? So that is not important. Okay, BP में कहाँ पे split है? This is gonna be subepidermal, right? So this is gonna be subepidermal. The antigen is BP antigen 2 more than 1. DIF is gonna show you what? A linear pattern, which is IgG C3. Vidhi, just send me a DM. I will add you directly. Okay. Pemphigus gestationalis, can I say same thing? Same thing, everything same except the patient is going to be pregnant. यहाँ पे क्या हो गया? Name itself is going to tell me linear IgA deposition. DH subepidermal only, but what kind of IgA? Now it's going to be granular, picket fence appearance, granular IgA appearance. Got it? So this is our entire summary of vesicobullous, which gets you one question for sure in every exam that you'll attempt. Okay, so ये हमने कर लिया आधे घंटे में. Just one mimic, if it is drug induced, if you are seeing drug induced oral involvement and you have diffuse body involvement, two things, it can be SJS10 spectrum, right? So how much body is involved? We'll call it Stephen Johnson syndrome. Call it less than 10%. How much area is involved? We call it 10. More than 30. Toxic epidermolysis necrolysis, right? So this is 30%. In between, we call it overlap, right? SJS10 overlap. So this is about the syndrome. I'll tell you. Okay, 10 is not 10. Huh? Can you revise the again? Previous slide was revision only, no? Just see the class again, hai na? So this is SJS and 10, right? Here, what are the drugs which are responsible? So you have antibiotics which are predominantly important, but in the exam, you will invariably get one of these. Or hamesha पूछते lamotrigine, right? Lamotrigine is favorite for examiners, but overall most common would be antibiotics, TMP, SMX, beta-lactam, fluoroquinolones, anti-epileptics, NSAIDs, allopurinol. So I've given you a list. Just remember, broadly, pura category do not have to remember. No need to remember. Any drug, basically it can cause. Have in mind lamotrigine at least, okay? Erythema multiforme is not same as SJS. No, we saw, na? Erythema multiforme had target lesions, right? So when you have a singular target lesion, that is erythema multiforme. But when we have this diffuse blistering vesicobullous disorder, that is SJS10, right? Okay? So, ye hai. What is this now? When you see an infant, When you see an infant who has blistering lesions, intraepidermal split है इसमें भी. So what kind of bulle will you see? You will see very, very flaccid bulle here. Will there be oral involvement? No oral involvement. Very, very important. No mucosal involvement, right? So the diagnosis is now staphylococcal scalded skin syndrome, which is also called as Ritter's syndrome. Do you remember Ritter's जो हमने कल करा था? Yeah. Yesterday we also saw that staph has exfoliative toxin, right? That is where it was causing what? It is also causing impetigo, which was bullous impetigo. So when that becomes very severe, it's called staphylococcal scalded skin syndrome. Remember, it will not have oral involvement. One differential for this, when you have a child who again has all of this dermatitis, which is called as flaky dermatitis, you are losing skin. What is the diagnosis? Yes. So remember this flaky dermatitis, you'll see a very malnourished child, pot belly hoga, very weak. It is kwashiorkor. And another sign for kwashiorkor based on dermat, one is F for flaky dermatitis, the another one is F for very nice flag sign. So you'll see that suddenly the hair is turning white. Okay, so that sudden white is flag sign. What was the other thing where we saw a white hair turning white overnight? Yes, alopecia areata. उसमें क्यों हो रहा था? Because he was losing rest of the hair. उसमें तो white hair spare हो रहा था, right? Whereas here there's whitening which happens. So this is flag sign. Okay, so this is about that. ठीक है? Cool. So now there are these signs that you need to know. So what is this sign that you are seeing here? When you apply lateral tangential pressure, you will see कि membrane जा रही है. So in what kind of lesions do you think this could happen? This is your Nikolsky sign. Can this happen when you have a tense bulla with a thick wall? No, this cannot happen in subepidermal, right? So this will only be seen in intraepidermal lesion. So this is only seen in pemphigus. Can it be seen in staphylococcal scalded skin syndrome? Yes, that was also superficial only, right? That was also intraepidermal. But can I see this in BP? That is the important part. No, you cannot see it in BP. Khali lateral pressure lagane se the wall will not give way. So that is Nikolsky sign. The other sign that we have here is bulla spread sign. Now you are not applying tangential pressure. You're just pushing lateral pressure laga rahe ho. You're just pushing the bulla. So depending on the shape, if you see that it extends as a rounded extension hai, that is bullous pemphigoid. But when you see that angular extension hai, that is pemphigus vulgaris. How to remember? See, vulgaris has this angle, है ना, angle. So remember, vulgaris will show you V जैसा. But when you have this is bullous pemphigoid. On the other hand, what is this? This is your Asbo-Hansen sign. Asbo-Hansen sign में what we are doing is we are applying pressure on the roof. ऊपर से दबा रहे हो. On the roof you are applying pressure. So now what will happen? Again, you will basically, this is something which is positive in both. It is seen in bullous pemphigoid also, and it is seen in pemphigus vulgaris also. So this is seen in both, wherein when you apply pressure on the dome, it will basically spread out. Okay, so this is not very, very important. Okay, so basically Nikolsky and bulla spread are two signs which are important. ठीक है, so this takes care of Vasicobullus, lots to do. So अब हम जाएं, positive Nikolsky is this, no, whenever it spreads, whenever this membrane gives way, that is positive Nikolsky. Okay, so now we go to pigmentation. Pigmentation पे पहले hyperpigmentation करते हैं. So when you have lots of hyperpigmentation in the epidermal layer versus dermal layer, how do you distinguish clinically? Epidermal में how will it appear clinically? It will appear brown in color, and it will appear brown or black. When it is dermal, the typical color they will either use a slate gray or it will appear bluish, right? So slate gray or bluish color likhega. Why? Correct, because of Tyndall effect. So this is because of Tyndall effect. One more way to distinguish apart from color, if you use a UV, Woods lamp examination. So what will be enhanced? Yes, on Woods lamp examination, the epidermal would be accentuated, whereas dermal will not be accentuated. Okay? So these are two distinguishing factors of epidermal hyperpigmentation versus dermal. Very, very important spotter. One out of these images is going to come in the exam. When you give history ki OCPs tha, pregnancy tha, basically hormone related, progesterone related pigmentation hai. This is cloasma or melasma, right? So this is basically mask of pregnancy, which is your cloasma or melasma. So this is what you are seeing here. For depigmentation, for treatment of this, what can we use? First of all, will this reverse after pregnancy? कि baby deliver हो गया फिर ये reverse हो जाएगा? This will not reverse. So, out of personal experience only, I can tell you, in pregnancy, you have a lot of hyperpigmentation in the neck and in the face. You get a lot of hyperpigmentation. Everything resolves, but melasma doesn't resolve. This is one thing which doesn't resolve. So, correct. We have a lot of cocktails that we can give for treating it. One such cocktail, as you are all correctly saying, is called Kligman's formula है ना. इसके आसपास भी दो तीन formula है, but the main drug is hydroquinone. So hydroquinone is something which is gonna give you depigmentation, right? So hydroquinone we are using along with tretinoin, dexamethasone, so this is the formula that you are using to treat it. Now, what if you use excess of hydroquinone? So I want to do two things here only. If you use excess of hydroquinone, sometimes it can backfire. You can actually cause bluish hyperpigmentation if you use excess, which is called what? That is called as ochronosis. Remember ochronosis of alkaptonuria? So this is called ochronosis, but this is what? Endogenous or exogenous? This is called as exogenous ochronosis. All right. So remember hypo करा रहा था, but बहुत करने पे contradictory hyperpigmentation हो गया. Similarly, one such thing which is called as contact leukoderma. So do you agree that if hydroquinone is causing hypopigmentation, if I use a chemical compound which is called monobenzyl ether of hydroquinone, which is seen in rubber, है ना? Rubber में क्या है? Monobenzyl ether of hydroquinone. So when you wear rubber slippers, you can have whitening there. So this is contact leukoderma. So I'm just trying to correlate this for you so that you can remember it together, है ना? तो hydroquinone is the culprit agent. अगर ज्यादा हो गया तो exogenous ochronosis. अगर rubber में आ गया monobenzyl ether of hydroquinone, that is contact leukoderma. साथ में ही contact leukoderma दो और कर लेते हैं. So बिंदी doesn't have this is only in rubber, right? बिंदी has adhesives. तो adhesive में क्या है? It is para-butyl phenol. So this is seen in adhesives which is used in bindi. So two other contact leukodermas. So these are very favorite questions, no? So contact leukoderma, this is this. And para-butyl catechol कहाँ पे है? Very nice. This is seen in hair dyes, right? So both of these are also, things that you can remember. Do not confuse them, guys, with contact dermatitis, allergic dermatitis, because I have done that. I remember in the past I used to mix it all up, and I'm sure you guys are also thoda like me. So do not mix them up. This is for depigmentation. This is not dermatitis, है ना? This is leukoderma. ठीक है? So I will save you wherever you are going to make mistake, because I've been there, I've done that. Okay, so this is melasma, cloasma. Going back to hyperpigmentation. ये क्या है? यूएस में बहुत बच्चों को मिलता है. This is freckles, mainly seen in Caucasians. So all of these are what color, guys? Brown है. So what layer are we dealing with? We're dealing with epidermal, right? So epidermal hyperpigmentation है in all of them. Correct? That is established. ठीक है. Third thing, brown तो है, but साथ में hair भी आ गया. So along with that, you also have hair. So what is this kind of a nevus? Yes, this is nevus of Becker. So this is Becker's nevus when you see hair along the acromioclavicular region. And very important, last year ka sawal, they'll give you arthralgia, they'll give you fever, joint pain, retroorbital pain, and you see pigmentation on the nose. Yes, this is chick sign of chikungunya, hai na? So very important. So chikungunya, again you'll see hyper pigmentation here. Okay, very very important. Next, we go to dermal pigmentation. So when you see a baby, newborn baby having these bluish spots, you know it's dermal pigmentation. What is the diagnosis? This is Mongolian spots. What will you? So all of these are blue, right? So that is why the general term for all of these is ceruloderma, right? So इन सबको हम ceruloderma in general बोल सकते हैं, because it is blue dermal pigmentation. ठीक है? Mongolian spots के parents को क्या बोलोगे? Will it resolve? Will it not resolve? My daughter Zara has Mongolian spot. क्या बोलोगे मुझे? But it has still not resolved. मेरी बेटी तो 9 months की होने को, it is still not resolved now. Should I get it operated? What will you tell me? Tell me कि मैम रुक जाओ, हो जाएगा. ठीक है, just रुक जाओ for 1 year. Mostly it will go in 1 year. If it doesn't go in 1 year, it will go in 5 years, right? So just hold on, निकल जाएगा. Okay, so this is Mongolian spots. Okay, then what do you have? It's a very cute, it's a very cute spot, Mongolian spot. Okay, what do you have in blue lesions? Right, so this is nevus of Ota. हाउ टू रिमेंबर ओटा, इट इज इन ओ फॉर ऑर्बिट. तो ऑर्बिट में अगर ब्लू ब्लू चीजें हैं तो ओटा हो गया, राइट. एंड वेयर इज इट सीन? या इट इज सीन अलोंग द ऑफ्थैल्मिक और मे बी maxillary division of trigeminal nerve. Okay, so this is much like what other thing which also spreads along V1 more commonly than V2. What is the other thing we are going to study today? Port-Wine stain, right? So Port-Wine stain of which syndrome? Sturge-Weber syndrome. Remember, that is also bluish lesion, which is actually a Port-Wine stain. It's not just this bluish pigmentation. Okay, so that's also most common along V1. Very nice. And what is this? When you have it along the shoulder. So do you know eat? Bricks are called eat, right? So eat we bear on the shoulder. Laborers will carry on their shoulder. So this is nevus of ito. Why I'm saying eat and this? Because you will confuse this. Ito भी confuse करोगे and ओटा भी confuse करोगे. तो अभी तो बताया है ना. जस्ट रुको, डाउट अगर पूछोगे नहीं तो आंसर खुद मिलेगा. So this is nevus of ओटा and this is nevus of ito. See how much time you wasted in typing. तो ऐसे ही बता देती मैं. So this is nevus of ito and this is seen in shoulder, है ना. So this is seen along the acromioclavicular region. Fine. So these are all your pigmentation. Now let's go to something where pigment ही नहीं है. Why you don't have pigment? Because you have no melanocyte. Why you have no melanocyte? Because here you have anti-melanocyte antibodies. So this is an autoimmune disorder which is vitiligo, which is associated with other autoimmune disorders like Hashimoto's and stuff, right? So this is vitiligo. There are various patterns of vitiligo. So when you have one or two singular patches, it is called focal. One subtype of this, if you have it in the mucosa, it's a mucosal variant, mucosal vitiligo. Okay, yeah, hypothyroidism also. Segmental means it's along a nerve distribution. Yes, so this is your segmental variant. Image based question aaya tha in one exam showing you segmental. Then if you see ki acral, I mean extremities and facial, acrofacial involvement, what will you tell this patient? Good prognosis, bad prognosis? Acrofacial particularly has bad prognosis. And is this the same as lip tip? No, this is not the same as lip tip. Lip tip is the sixth variant. Lip tip mein lip and tip of genitals, right? That is going to be involved. So that is different. It's not the same as acrofacial. Okay, acrofacial has bad prognosis. Apart from that, the most common, जिसको हम क्या बोलेंगे बताओ? Vitiligo vulgaris again. So vitiligo vulgaris, most common is your generalized form where you have bilaterally symmetrical patches. When you have how much involvement, you will call it universalis, because इसमें भी देखो sparing तो है. More than 90. If more than 90% of the body is involved, it is universalis. What will you tell this patient? Good or bad prognosis? Obviously bad prognosis, right? So it will not respond to treatment very much. So apart from these, what are the other things which have bad prognosis? Acrofacial means acryl means extremities, no? Facial means face. So this will involve the extremities and the face. Tell me other poorer prognosis. Yeah, it can be 100% also. Why not? Yeah, so one is long standing. The other poor prognostic factor, one, chronic disease. Long standing is poor prognosis. Second, anytime you have bony prominences which are getting involved, bad prognosis, will not respond to treatment. And one that you said, when there is leukotrichia, correct. When you have hair which is turning white, leukotrichia bhi hai. All of these are markers that there will be a poor prognosis, means response to treatment will be poor. Treatment, I have not gone into treatment in detail because सवाल ही नहीं आया कभी. But initial would be topical steroids. You can apply topical tacrolimus. Eventually, you want to give Soralens and you want to give phototherapy, right? So Soralens देके phototherapy. That is one question which has been asked कि Soralens किस में use करोगे? So when you study detail पूरा इतना नहीं पूछते. And finally, if it's not resolving, then you resort to systemic steroids and systemic immunosuppressants. That is almost the general trend for everything in derma. है ना कि टॉपिकल स्टेरॉइड से स्टार्ट करो एंड देन गो टू सिस्टमिक. कूल, राइट. नाउ दीज आर द क्वेश्चंस दैट यू विल बी आस्क्ड. इमेज बेस्ड क्वेश्चन. ओके, what do you have here? When there is this hypopigmentation, but now this is not because of melanocyte damage, this is because of vasoconstriction, right? So what is this? This is nevus anemicus. So this is nevus anemicus because it's white, but this is actually because of vasoconstriction, because there's some problem in the alpha receptors. Okay, right. हाँ, बाकी normally है. So you'll see just a patch of hypopigmentation. So now hyper कर लिया, अब हम hypo में पहुंच गए ना vitiligo के साथ. This is the hypopigmentation area. Now whenever you see this, इसको क्या बोलेंगे? White forelock. The moment you see white forelock, I want you to think of two differentials. If I show you something like this, what is the diagnosis here? This is heterochromia iridis. Can you see iris has different color? In addition, if I tell you that this bacha also has sensory neural hearing loss, diagnosis? Yes, diagnosis here is going to be Waardenburg syndrome. But if I tell you white forelock के साथ ऐसा appearance है where you have these segmental hypopigmentation, islands of sparing, what is this? Please write clear. Okay, this is piebaldism. Okay, so this is piebaldism. Fine, so these are the two syndromes that you have. Yeah, so you have Waardenburg syndrome and you have piebaldism. Okay, Waardenburg syndrome. Okay, ठीक है. So this is when you have white forelock. And ये क्या है? When you have hypopigmentation along the Blaschko lines. This we have also studied in hyperpigmentation. उसमें था nevus of Ito. यहाँ पे क्या हो गया? Hypomelanosis of Ito. So this is when you have hypopigmentation along the Blaschko lines. One question had come on just recognizing Blaschko lines. They had given you SSA lines and they had asked you ki, what are these lines? So these are the Blaschko lines, which are the lines of development of skin. These do they correspond to dermatome, sclerotome, myotome? No, it doesn't, right? So this is not going to correspond to anything. These are just embryological distribution of the skin. So this is Blaschko lines. Is this X-linked dominant? No. There is one more disease which is occurring along Blaschko lines, which I am showing you here, which has 4 stages. What is this? Yes, this is incontinentia pigmenti. What is the inheritance here? So this is X-linked dominant. कल एक disease की बात की थी correlate करते करते X-linked dominant. What was that? Alport's disease, right? So today we have studied one genuine disease, which is incontinentia pigmentis. This is going to have 4 stages. One question had come on the stages. So what are the 4 stages that are going to be seen here? In the first stage, you will see bullous, जो हमने पहले पढ़ा आज. You will have vesicles or bullous. In the second stage, can you see how there are verrucous warty lesions? So here you will have verrucous involvement. And in the third stage, you will have hyperpigmentation. And final stage, you will have hypopigmentation. So how to remember? Is this the pattern in which we have studied also? आज के क्लास में पहले हमने बुल्लस पढ़ा, वरुकस ठीक है पढ़ लिया छूट मूट का. Then we studied hyperpigmentation and dermal epidermal, and finally we studied vitiligo, hypopigmentation. I did not think this, but अभी ऐसे fit हो गया है ना. So this is how you can remember. And they had asked you hypopigmentation is seen in which stage? So it is seen in the 4th stage, है ना, जो हमने आखिरी में पढ़ा. So ऐसे याद रख सकते हो. Fine. One of you asked, is this along Blaschko lines? Yes. So इसके जो pattern होंगे, this is along the lines of Blaschko. Okay. वेरुकस टंग भी पढ़ा था. अरे वाह, वेरुकस टंग भी पढ़ा था, है ना. तो बीच में प्रेमलता आई थी. सो वेरुकस, है ना. सो दिस इज अबाउट इनकॉन्टिनेंशियल पिगमेंटाइट. वेरी नाइस. ओके, सो दिस इज अबाउट दैट. ये हमने ऑलरेडी कर लिया, कॉन्टैक्ट ल्यूकोडर्मा. एंड फाइनली व्हेन दे गिव यू दैट ड्रग का हिस्ट्री था, एक तो याद रखोगे SGS10, बट व्हेन यू सी पिगमेंट एंड अगेन व्हेन यू सी ईदर फेस इन्वॉल्वमेंट और यू सी पिनाइल इन्वॉल्वमेंट, so specific, this is fixed drug eruption. Name only tells you that it's going to occur at the fixed same site, है ना. The drugs which are mostly responsible, most common is going to be a category of NSAIDs. Apart from that, antibiotics, anti-neoplastic, everything, but just remember NSAIDs and tetracycline as the prototype. Okay, so this is so typical when they give you penile lesions. No, this is going to be there. So this will start as erythematous lesions. So this can have reddish lesions early on, but later on, can it leave hyperpigmentation? Why are we studying this in pigment? Because this can leave hyperpigmentation behind. Okay, so this is also one favorite question of AIMS examiners. So ये तो गलत नहीं करोगे, हाँ? This can occur with any drug, no? I mean, doxy also, why not? Yeah. So the history should be typical कि penile face जगह पे आ रहा है, same site पे हो रहा है, erythematous followed by hyper. No patch test here. We will come to it. Dermatitis will come to it. Okay. So drugs can have a variety of things. Anu. This is not targetoid lesion. Targetoid was erythema multiforme and erythema migrans. Okay. So erythema multiforme also could have drug history. SGS10 can also have drug history. FD can also have drug history. So now depending on the presentation, we have to distinguish. Got it? प्रेजेंटेशन में वजाइकोबुलस है डिफ्यूज, तो वो SGS10 है. इफ इट्स सेम साइट पे एरिथेमेटस फॉलोड बाय हाइपरपिगमेंटेशन, FD, लाइक दैट. Okay, so now we go into the big category of miscellaneous disorders. फटाफट करते हैं, lots to do guys. बताओ ये क्या है? When you see this large ulcerative lesion, and what do you see histopathologically? That in the dermis you see this fat, right? So we are deep down in the dermis, you are seeing so many neutrophils. Correct. So this is PG, pyoderma gangrenosum, very typical spotter. So this is pyoderma gangrenosum. Again, this is related to ulcerative colitis. यही में जाता है ना, यही आएगा. जो images मैंने दिए ना वही आएंगे. This is pyoderma gangrenosum. And what do you see here? This is deep neutrophilic dermatosis. Okay, neutrophilic dermatosis. One more thing, apart from PG, which is also deep neutrophilic dermatosis, the neutrophilic dermatosis I've been seeing so many times. Yeah, this is sweet syndrome. Yeah, so the sweet syndrome and pyoderma gangrenosum, दो चीजें हैं. Sweet syndrome is या गुड अभी ऐसे कुछ भी रैंडम. गुड सिंड्रोम विद थाइमोमा. करेक्ट. सो स्वीट सिंड्रोम, ऐसे तो सब अपने अपने जिनको जो आता है वो बोलने लगेगा. तो स्वीट सिंड्रोम, रिमेंबर, is something where you have neutrophilic dermatosis, and you will have fever and you will have generalized things along with such lesions. Okay, so both of them are examples of this. Right, now we go into ichthyosis. For certain reason marrow GT is always a question on ichthyosis, and for one point of my life people were after me कि मैम ichthyosis पढ़ा दो, but I never gave in. But finally today I will teach you ichthyosis. Okay, so ichthyosis are of four types. So one is ichthyosis vulgaris, obviously most common. You have X-linked ichthyosis, less common. Exam में most common, lamellar ichthyosis, which is also called as a very big name which you don't need to remember, lamellar ichthyosis. And the worst is harlequin ichthyosis. Yeah, not ichthyosis for FMG particularly, but baki sab kuch is for FMGs. Yes. Okay, so ichthyosis vulgaris, first of all, what will be the typical pattern? Ichthyosis ka meaning kya hai? It means fishnet, right? So you are seeing this fishnet kind of a pattern here. What is the inheritance of ichthyosis vulgaris? Let's see here only. So this is autosomal. यहाँ पे semi-dominant there, it's usually autosomal dominant, right? So autosomal dominant होता है. So this is your typical ichthyosis vulgaris, when you have extremities which have this very scary looking fishnet pattern. This is a very scary disorder. Okay, this is a ichthyosis vulgaris. Yes, I'll just get to that. HM. So I vulgaris. What happens in X-linked ichthyosis, guys? X-linked inherited ichthyosis, maybe will you see similar sort of pattern? Similar sort of pattern, but now what will be the problem? The difference would be, one, it will be seen in the trunk, right? It will be seen in the trunk and the torso. This will be in the extremities. So that is the first difference. Second, you will have various associations in XLI. One association is Kalman syndrome. Remember Kalman syndrome, where you have hypogonadism and you have anosmia, right? So that will be one association. The other association is androgenetic alopecia, male pattern, female pattern baldness. This you will not find anywhere. Okay, so this is X-linked inheritance. So this I studied in very much detail for some reason. So this is I vulgaris, this is XLI. What is this? This came as image-based question. So here they will give you history that at birth baby was covered in membrane, isn't it? So yes, so this is your colloidal baby which is enclosed in a membrane. What will you tell these parents? Obviously parents are going to be very worried, right? कि क्या होगा, ये membrane निकलेगा नहीं निकलेगा? This membrane will be shed off, right? So within 2 to 3 weeks this membrane will be shed off. You can't reassure, so this will be shed off, but that can lead to erythroderma, right? So there can be erythematous involvement. There can be a lot of problems later on. What kind of problems? When you have all the skin which is shedding off, they will have a lot of non-sensory insensitive heat loss, right? So heat, AGA, androgenetic alopecia, so they'll have a lot of heat loss. So इनका electrolyte, heat, sweat loss, ये सब हमें manage करना है, right? So they will be dehydrated and they'll have electrolyte imbalance. So that needs to be managed vigorously throughout their lives. And the most severe one, like just so feeling so sad looking at this baby, this is harlequin child, right? And this obviously has a very poor prognosis. When you have such a thick armor of membrane, this is harlequin baby, है ना? So no, This image is vulgaris, extremity hai na, so this is ichthyosis vulgaris. If you see similar pattern on the trunk, it is XLI. Okay, so this is colloidal, this is harlequin. You've seen one, I've also seen one at Ames. Very bad, you know, no, not compatible with life. So now let's do a few important points. Ichthyosis vulgaris, yeah, girlfriend, is it? I do, anyways, chodo. Ichthyosis vulgaris, autosomal dominant, this will be seen in infancy. Extremities में मिलेगा fine scales. Do you remember yesterday we had phylagrin? Yes, so there's problem antibodies against phylagrin, which will you see in ichthyosis vulgaris. In X-linked, this will present early onset. Abdomen पे lesions मिलेंगे. The scales will be larger and darker, and the problem is with steroid sulfatase. So can you bring these together, guys? I vulgaris, fishnet, tiny, tiny in the extremities. More severe in the trunk, darker, associations है, and the problem is with steroid sulfatase. ठीक है, फिर इसको भूल जाओ. Lamellar ichthyosis will present at birth with a membrane. Problem is with transglutaminase 1. And the rarest harlequin problem is with ABCA 1-2. So this is the maximum you need to remember. इसमें भी पता नहीं क्या ही सवाल आएंगे. In the exam, they have given you this image and they have asked you diagnosis. So diagnosis is going to be lamellar ichthyosis, colloidal baby. Got it, everybody? सब शांत हो गए अचानक से. Got it? Okay. ठीक है. Are you guys all right? Okay. So now we go to contact dermatitis. Okay. Now we go to contact dermatitis. Sundra, very good. So we have exogenous and we have endogenous. Okay. So exogenous contact dermatitis means bahar ki cheezon se ho raha hai, isn't it? So here you can have three kinds of things. So one, in women who are using a lot of detergent, haath dho rahe bahut. So what do you call that? Yeah, so this is irritant, right? So irritant, because detergent is an irritant, so irritant contact dermatitis हो गया ये. ठीक है. हाँ, yes. So one thing which I forgot, ichthyosis can be acquired also. How can it be acquired? So you guys do your homework. If you did your homework, this answer you will tell me. mer 29 उस दिन मैंने दो ichthyosis बताए थे. You have seen, everybody, mer देख के आए हो, and you have seen STD का MKT also. Very good. So clofazimine can induce ichthyosis, and which variant of leprosy? Very good. Pure neuritic variant of leprosy. How will the indeterminate variant of leprosy present? बच्चा दिया होगा with a face hypopigmented lesion. इसका DD क्या है? DD is pityriasis alba. Which one will have scales? P alba. Which one will be itchy? P alba. Which one will have atopy? P alba. Which one will have sensory loss? Indeterminate. ठीक है. So this is how you distinguish both of them. Okay, very good. ठीक है. तो अब यहाँ पे जाते हैं. This is irritant contact dermatitis. So if it is irritant, can it be seen in the first exposure? Yes, this can be seen in the first exposure also. Will you see any hypersensitivity here? Irritant में कोई hypersensitivity नहीं है, right? So this is, are there any memory T cells which are going to be formed? No memory T cells will be formed here. On the other hand, when you have some sort of allergy, first क्या है डॉग? ये first. So this is your hands. So these are your washerwoman hands or your detergent hands. So इनको बोलते हैं washerwoman hands or detergent hands, where you have just redness because of irritation. On the other hand, when you have allergy which is induced, so this is called as allergic contact dermatitis. Will this occur in the first exposure or second exposure onwards? This will be second exposure onwards. And will you have memory T cell? हाँ, एफएमटी में भी था, बट दैट वाज डिफरेंट ना. वो तो ड्राउनिंग में मिलता है, पानी में मिलता है. विल स्टडी एफएमटी. अभी नेक्स्ट ही तो है. नेक्स्ट क्या है? पीड्स है ना कल से. गॉड, आई हैव टू स्टडी पीड्स. ओके, द सेकंड, एंड वी हैव मेमोरी टी सेल्स. ओके, सो व्हाट आर द कॉमन एलर्जेंस? सो व्हेन यू सी दिस एंड आई आस्क यू कि बताओ क्या एलर्जन है? ज्वेलरी इंड्यूस्ड. या, सो इन ज्वेलरी, इन आर्टिफिशियल ज्वेलरी जो हम पहनते हैं, दैट इज निकल. अच्छा, ये पूछ रहे हो फर्स्ट क्या है? फर्स्ट एक्सपोजर. ठीक है, अपने अपने में समझ के बता दिया करो. निकल एंड ज्वेलरी. सो ज्वेलरी इंड्यूस्ड डर्माटाइटिस है, वो है निकल. ठीक है. पोटेशियम डाइक्रोमेट किस में मिलता है? व्हाट इज दिस एंटीजन फॉर? वेरी नाइस, दिस इज इन सीमेंट. सो हाथ का दे सकते हैं इन सीमेंट वर्कर एलर्जिक डर्माटाइटिस. थियूराम इज सीन इन व्हाट, व्हिच आई एम ट्राइंग टू शो यू हियर आल्सो. इट इज इन रबर, है ना. So see, rubber slippers producing two things. If rubber slippers are producing white, What is that? Different disease. इसलिए confuse होते हैं बच्चे. That is contact leukoderma, है ना? That was because of the hydroquinone का वो which we saw, methyl whatever. ठीक है, so that was for MBEH. On the other hand, when it is because of dermatitis, when it is this lesions, red lesions, that is because of theoram antigen. Okay, cobalt chloride कहाँ पे मिलता है? This is seen in tattoos. All right, so tattoo में ये antigen होता है. Very nice guys. Tattoo dyes में, ठीक है, colorful tattoos कराते हो तो हो सकता है cobalt chloride. Okay, so this is allergic contact dermatitis. Friends नहीं, मैं ही बताऊंगी. 39 out of 70. Okay, but I also have a friend. 39 out of 70. What is this that you have? ABCD. When you see कि sun exposure, when you see कि exposed area पे हो रहा है, what is ABCD? Airborne contact dermatitis. ठीक है? So this is when the antigen is traveling through air. So face, neck, exposed area. So here the trick would be exposed areas are getting involved. What is the problem? The problem antigen is this. Parthenium hysterophorus is the plant, which is also called as Congress grass. And the antigen which it has is this very complex name, which is sesquiterpene lactone. ठीक है, so don't even bother remembering this. एग्जाम में आएगा तो पहचान ही लोगे, है ना? So कांग्रेस से एलर्जी हो रही है, एयरबॉर्न कॉन्टैक्ट डर्मेटाइटिस. So whenever you have these known things कि यार इनसे हो ही रहा है सबको पंगा, so we want to see, right, if when the patient comes to you with suspected allergic contact dermatitis, you want to do this test. This has been asked so many times, right? So the investigation of choice for contact dermatitis is gonna be patch test. तो पैच टेस्ट में ना हम ये चेम्बर्स भरते हैं. What are these chambers called? These chambers are called fin chambers, है ना? तो fin chambers में हमने we have filled different antigens and फिर हमने भर दिया, right? Now I will call this patient at what time? Repeat question. Very good. We'll call him after 2 days and we'll call him after 3 days. We'll also call him after 4 days, but the most specific, yeah, so 48 and 96, 2 and 4 basically is when we are calling him. 2 days and 4 days, and then we will see कि कहीं पे भी redness, vesicles या inflammation basically हुआ, that means that that was your allergen, है ना? See, again you made that mistake. Was that dermatitis? Bindi was dermatitis or Bindi was leukoderma? इसीलिए मैंने बताया था, I have kept it in 2 different chapters. That was depigmentation, that was leukoderma, that is not dermatitis. ये समझ में आया? I have also made that mistake. तो ये सारा dermatitis है, वो hypopigmentation था. ठीक है, समझ में आ गया? Right, so this is about patch test. Now we go on to other endogenous dermatitis. तो ये सब तो बाहर की चीजों से हो रहा था. Treatment is exposure. Avoid exposure in all of these. ठीक है, तो नहीं होगा. Now in endogenous, हमारे वजह से dermatitis. So when you see this sort of a coin lesion, what is this? This is discoid. Again, this morphology has been tested. What is this morphology? This is discoid morphology, right? So this is nummular or discoid eczema. All of these are eczemas that we want to study. When you see that in the dependent location, patient will give you history of varicose veins. What is this sort of a dermatitis? Yes, this is stasis. This has been asked and this can be asked. Stasis dermatitis. अभी तो शुरू किया है. This is the first subject, stasis dermatitis. So gravitational, you will see along the venous side, है ना, medial side पे मिलेगा, where you have lipodermosclerosis and everything. So this is stasis dermatitis. When you see yellow things, yeah, CAP classification, I'll teach you in surgery. This is seborrheic dermatitis. So this is different from seborrheic keratitis that we had done yesterday, right? So seborrheic keratitis was the one word which you had to remember. To diagnose, it will have a Saucehi stuck on appearance. And the other thing that you want to remember for seborrheic, if you see multiple seborrheic keratosis, sign of lesser trellat, which will point to internal malignancy. But this is different. This is seborrheic dermatitis. And if you see this in a newborn baby, this is called what? This is called cradle cap. Again, cradle cap suppose मेरी daughter को नहीं था, but अगर होता तो what will you tell me? कि मैम चिल मारो निकल जाएगा? Yes, it can be an underlying sign of LCH, but otherwise you just reassure कि निकल जाएगा, right? We use specific shampoos and sabun वगैरह use करके it usually goes away, है ना? So this is cradle cap. Yeah, same as dandruff basically. So what is this? The final one, when you this we have seen yesterday. Good. This is asteatotic eczema, or when you see such dry skin and then you have eczema. Very good. So this was seen when you have absence of Ordland bodies. Remember, Ordland bodies were there in the granules, है ना? So this is Ordland body का deficiency, osteotic और winter eczema. ये winters में ज़्यादा होगा. Okay, lamellar granules में. Very nice, guys. Okay, right. How will atopic dermatitis present? So एक तो history. I will show you one criteria. So atopic dermatitis, first of all, कैसे याद रहता है? I don't know. See, I tell you the quickest. Shall I tell you the मैं तो बस पढ़ती हूँ और मैं पढ़ा देती हूँ. Like this is all material of one day. तो एक दिन पढ़ो, सबको पढ़ा दो, मुझे याद रह जाता है. So that is why teaching is so effective. You know, किसी को पकड़ो और पढ़ाओ, चाहे वो इंटरेस्ट है, छोटे भाई बहन को पकड़ो और बिठा के पढ़ाओ. Right? When you teach, no, you will remember stuff. Obviously I forget after one class, but then I revise my own class and I will remember somehow. Matlab, I don't want to brag, but somehow I have a tendency that when I speak, people who listen to me will remember stuff. You can take it from whoever has studied from me, but you will tell me also later on कि जो मैंने पढ़ा है वो आपको शायद याद रहेगा. Okay, so now I am revising my own classes. When I revise my own class, no, I actually remember. ऐसे मैं खुद की तारीफ कर रही हूँ, but hopefully you will also tell me the same, that you will remember. ठीक है, शायद. So this is something about the way I talk probably. Anyways, so atopic dermatitis. हाँ, dog को पढ़ाओ, किसी को भी पढ़ाओ ना, जो भी मिले, you just speak it out, you always remember better. ठीक है. हाँ, बोला था ना रवि ने. सी एटोपिक डर्मेटाइटिस. सो एटोपिक डर्मेटाइटिस में अगेन अक्यूट का बताओ. चलो देखो, वी विल सी लाइव हाउ यू रिमेंबर. कल हमने पढ़ा था इन अक्यूट एक्जिमा व्हाट वाज द लेयर. सी यू गाइस रिमेंबर, वी विल हैव स्पॉन्जियोसिस. अब स्पॉन्जियोसिस में देखो, अगेन वी विल टेस्ट वाज इट इंट्रासेल्युलर एडिमा और इंटरसेल्युलर एडिमा. इंटर है ना. इंट्रा क्या था? बलूनिंग डिजेनरेशन. खुद का ही इंट्रा होगा तो बलून हो जाएगा, HSV. दिस इज इंटरसेल्युलर edema. So anytime spongiosis is there, filling of water is there, intercellular edema. Do you think clinically also how will the manifestation be? पानी निकलेगा, so there will be these oozy vesicular lesions. So this will be oozy, such a oozy, है ना? oozy lesions होंगे, right? So you can't stop saying oozy. So oozy vesicular lesions. But when you have chronic things, what will you see? Correct, you will see acanthosis. Yeah, eczema, same thing. Acute eczema, atopic dermatitis. So this is acanthosis. Okay, acanthosis mein what will you see clinically? What do you see here? Too many lines, right? So line se yaad rakho, hallmark is lichenification. So you're going to see hyperpigmentation, lichenification, and chronic changes. What areas are involved? Correct. The predominant areas are going to be flexors. In infants, however, so adults may flexors. In infants, you will have face as well as flexors, right? And in infants who are crawling, जो infants crawl कर रहे, they'll also have involvement of extensors, right? So उनमें extensor involvement भी हो जाएगा. So remember, children में face and extensors can also be involved. The criteria which will tell you about everything that you need to know. Hanifin and Raj का criteria. So pneumonic कुछ नहीं, just see this, है ना? रटने की कोई जरूरत नहीं है, just see क्या क्या features है. Chronicity हो सकता है. Important history of atopic dermatitis. Areas we have already seen, flexures and face, so popliteal and antecubital fossa. And then you will also have pruritus. So what happens in atopic dermatitis is basically there's a lot of transepidermal water loss. So a lot of water loss happens, right? Oh, really? That's nice. Uh, Previous slide. Yeah, so transepidermal water loss will happen. So what results is this very vicious cycle of itch, scratch, itch. Have you ever been stuck in this vicious cycle where you itch and then when you scratch it, it further leads to more itching? Yeah, so this is itch, scratch, itch cycle that we can relate to, isn't it? Yeah, so this is pruritus and this is atopy. Correct. एवरी डे नहीं होना चाहिए. एवरी डे इज देन यू गेट योरसेल्फ चेक्ड आउट. एवरी डे तो नहीं होना चाहिए, बट कभी कभी. तो माइनर क्राइटेरिया में क्या है? नॉट वेरी इंपॉर्टेंट. बस एक बार सुन लो. एंटीरियर सबकैप्सुलर कैटरैक्ट, केराटोकोनस. बाकी आईजी टाइप 1 इज सेम. व्हाट इज डेनी मॉर्गन लाइन? डेनी, नो नीड टू रिमेम्बर, जस्ट सी एसोसिएशंस. डेनी मॉर्गन लाइन में ना यहाँ पे एक फोल्ड आ जाएगा आई के नीचे, बस उतना सा, इतना सा, जस्ट रिमेम्बर आई. रेकरेंट स्किन इन्फेक्शन ऑल्सो, क्योंकि वाटर लॉस हो रहा है. इक्थायोसिस वल्गारिस बिकॉज लाइकनिफिकेशन एंड फैशियल पैलर. ठीक है, सो बस इतना सा. बहुत सारे देर आर बिग लिस्ट ऑफ नेम्स. नो, सडनली आई एम रिमेम्बरिंग माई पीजी डेज. दिस इज बिग list. Nobody has asked this ever. Very quickly, malignancy, so much to do. Quickly, what is this malignancy? Pearly white nodules. The buzzword is pearly white nodules. And हमेशा नाक दिया होगा आपको, यहाँ पे lesion होता है हमेशा. Basal cell carcinoma. Histopathologically, what is the hallmark? Do you see cells stacked over one another? So this is true palisading. Pseudo palisading is seen in which brain tumor? Pseudopalisading, serpentine necrosis, glomeruloid bodies are feature of GBM. Very nice. They are all features of glioblastoma multiforme. Here you have true palisading. So what you will see typically is all of these are your clusters, nests of basaloid cells with peripheral palisading. And around these basaloid clusters, you will see this clefting, peritumoral clefting. तो ये सारी ही चीजें आपको मिलती है, राइट. सो दिस इज योर बेसल सेल कार्सिनोमा प्रोटोटाइप. व्हाट इज दिस? गुड, गॉर्लिंगॉट सिंड्रोम के साथ एसोसिएशन है. वंडरफुल. Yes, so this is your cerebriform nucleus. So this is your T cell, cytotoxic T cell, which is showing you cerebriform nucleus. Do you remember this from yesterday? So what is this? This is your Sézary syndrome. When it is hematogenous, but when it is just along the cutaneous T cell, it is just along the skin, it is cutaneous T cell, lymphoma or mycosis fungoides. What did we study yesterday about this? You will be seeing Potrier's micro abscess. So that we already know, where you will have lymphocytic collections. In addition, you see also one more feature which is called epidermotropism, where all of these cells are going towards the epidermis. Okay, so just remember one buzzword. Have you heard this? This is epidermotropism. No, interface dermatitis is different. It's not here. बस खाली इतना याद रख लो. ठीक है, वो पैथ में बताऊंगी. इंटरफेस डर्माटाइटिस, दिस एपिडर्मोट्रोपिज्म, पोर्ट्रियस माइक्रो एब्सेसिस, सेरिब्रिफॉर्म, टी सेल, ये सारा कुछ एक ही डिजीज में है. ठीक है, सो दिस इज ऑल अबाउट दैट. melanoma. Melanoma very very important, which these are all the types. बस एक मस्त सी slide मिल गई मुझे. Superficial spreading is the most common type. ठीक है, so this you will have a benign nodule to start with and then it becomes superficial spreading. So what are the signs that you will look out for to find out that this has become malignant? Yes, we follow the ABCD. This is your last year question. So what is ABCD? Full form मतलब इतना सा पूछा था. ABCD is seen where? इतना simple. So one, it becomes asymmetrical. Second, the outer borders become uneven. Then color changes, or very important number, diameter more than 6 mm, or in short, evolving. Shape, size, border, everything is getting changed. So 6 mm is what you need to remember. Now, so this is about ABCD. This is when you will suspect superficial spreading. ठीक है, ठीक है. हाँ, डेप्थ, हाँ, तो इसीलिए याद रखो, इट इज डायमीटर. राइट राइट, गुड. इट इज नॉट डेप्थ. व्हेन वी टॉक अबाउट डेप्थ, तो व्हाट इज द इंपॉर्टेंट डेप्थ दैट यू नीड टू नो इन मेलानोमा? Yes, it is the Breslow's depth. So Breslow thickness is basically the depth कि कितना नीचे जा रहा है from the epidermis, right? So this we need to know. So this is one of the most important, this is the most important prognostic factor, right? कि जितना deep जाएगा उतना survival. See how survival changes from 1 to 4 millimeters. आधा survival हो गया. Are you seeing this? So this is most important prognostic factor, which is Breslow's depth or थिकनेस, है ना. बट यहाँ पे याद रखो, इट इज डायमीटर नॉट डेप्थ. ठीक है, तो ये था सुपरफिशियल स्प्रेडिंग, जो ये एबीसीडी से बन रहा था. मोस्ट कॉमन. No, lymph node status is most common after Breslow's. This is still the most common, right? So in a primary lesion, it is Breslow's. But when you look at metastasis, then it becomes lymph nodes, right? So primary में पूछते तो Breslow's. But whenever it is metastasizing to lymph nodes, that obviously is also an important prognostic factor, but two different things. Are you getting my point? ठीक है. So this is about that. You will get the PDF. No, nodular is the one variant which is most aggressive. So this is most aggressive, worst prognosis, nodular. Then you have acral. Know the meaning of acral? एक्सट्रीमिटीज में होगा लेंटिजिनस, एकरल लेंटिजिनस. दिस इज समथिंग विच शोज यू वन साइन. नेल बेड के नीचे जब आपको ऐसा साइन मिलता है, व्हाट इज दिस? This is very nice, guys. This is Hutchison's sign. Whenever you see this pigmentation subungual melanosis, this is Hutchison's sign. And apart from that, you can have uveal melanoma, ocular melanoma. How will you distinguish this? Anytime you have something which is in the uvea, you can either have uveal metastasis or you can have uveal melanoma. Tell me one radiology feature of melanoma. This is how you distinguish this. No, not FFA dye. Very nice. We will do a T1 weighted MRI. If I see that it is T1 hyper intense, it is melanoma. Metastasis will be T2 hyper intense. So melanin, remember, is T1 hyper intense. So melanoma in the uvea or in the eye, choroidal melanoma will be T1 hyper intense. Okay. So this is about melanoma. Finally, कोई भी ulcer. हाँ, वैसे भी पढ़ाया है. Whenever you see अल्सर के अंदर chronic long standing margolin अल्सर में malignancy बन गया, it is your squamous cell. So burn के ऊपर margolin अल्सर पे, scar पे squamous cell carcinoma. ठीक है, टाइम बचा नहीं है. विल यू सी होमवर्क दे दूं? विल यू एम एमकेटी ऑफ सिंड्रोम्स? हाँ, तो सारे सिंड्रोम्स भी रिवाइज हो जाएंगे. ठीक है, तो ये देख लो. तो फटाफट से प्रीवियस क्वेश्चंस कर लेते हैं. सी एमकेटी ऑफ सिंड्रोम, न्यूरोफाइब्रोमेटोसिस, टीएससी आई हैव टॉट इन डिटेल, बिकॉज अभी तो मैं थोड़ा थोड़ा बताऊंगी, बाकी चीजें रह जाएगी, है ना. सी आई विल जस्ट टेल यू क्यूटेनियस मैनिफेस्टेशन राइट नाउ. इससे अच्छा कि पूरा सिंड्रोम देख लो तो सारी कुछ चीजें हो जाएंगी, है ना. एक तो क्लास देखो, थोड़ा होमवर्क देना पड़ेगा. ठीक है, सो सी एमकेटी सिंड्रोम्स. दो चीजें बस. whenever you see dimple, कुछ प्रेस कर रहे हो नोड्यूल को and it produces a dimple sign, diagnosis. ड से डिम्पल, ड से डर्मेटोफाइब्रोमा. ठीक है. And whenever you see that you are spreading and there's this redness, what is this? Very important. This is Darier's disease. No, this is Darier's sign, which is seen in cutaneous mastocytosis, right? तो mast cell का proliferation हो गया, जिसके कारण वो histamine release करते हैं. Urticaria. Do any of you have urticaria by any chance? Let's just discuss diseases. I have urticaria also. I don't know why. I just feel I have a lot of things going on. So urticaria I had at one point of time, but now it has resolved. So yes, urticaria will show you dermatographism. Wherein whatever you see, मेरे हाथ पे कुछ भी लिखोगे, it will produce red things because of the cholinergic response. Yeah. So फिर ठीक हो गया था. And it aggravates with hot bath and everything. There'll be this wheal, है ना, transient wheal मिलेगा, and then you will have urticaria. ठीक है, तो ये होगा. Yeah, I also took antihistaminics for some time, but then it automatically resolved on its own. तो अपने आप ही ठीक हो जाता है. ठीक है, so this is urticaria. ये स्टर्ज वेबर है. दिस इज द पोर्ट वाइन स्टेन दैट आई शोड यू. बाकी अगर टेलेंजेक्टेजियाज आंख में मिल रहे हैं, दिस इज अटैक्सिया टेलेंजेक्टेजियाज, एटीएम. ये सारा कुछ उसमें है सिंड्रोम्स में. दीज आर ऑल इन सिंड्रोम्स. फटाफट से बता दो. दिस इज म्यूकोजल न्यूरोमास विथ विच मेन somehow ये टेंडेंसी है कि तीन इमेज भी दिखता है तो दिमाग ओनली रजिस्टर्स प्यूच जगर फॉर सम रीजन. दिस इज सच एन इंपॉर्टेंट इमेज. एग्जाम हैज ट्रेन्ड अस सो मच कि जब तीन इमेज भी देते हैं तो प्यूच जगर ही दिखता है सबको. म्यूकोजल न्यूरोमा, दिस इज मेन टू बी. वेरी नाइस. व्हाट इज दिस? व्हेन यू हैव रेडिश लीजन्स. हर्पीस की एमकेटी है ना, वायरोलॉजी वाली. No, not bronchite Canada. This is hereditary hemorrhagic telangiectasias, which is also called as Osler-Weber-Rendu syndrome. ये सारा कुछ syndromes में है. And ये क्या है? Pigmentation, Peutz-Jeghers, right? So this is your Peutz-Jeghers syndrome, where you have hyperpigmentation. ठीक है? ये पढ़ लेना सिंड्रोम के क्लास में. सो दिस इज व्हाट डर्मेटोमायोसाइटिस. फटाफट बताई दो. दिस इज व्हाट पर्पलिश रैश. दिस इज हीलियोट्रोप रैश. What are these? Knuckles पे. These are Gottron papules. If I say that this female has recurrent vomiting episodes, very thin female who's coming to you, what will this same knuckle hyperpigmentation be called? No. पहले ये बताओ ना. Yes, bulimia. So bulimia में what do we call this? Whenever in bulimia you have all of these patches here, what do we call them? Yes, so that is the Russell sign. So that is the Russell sign in bulimia, wherein you have this hyperpigmentation and callus formation at the knuckles because of the purging, right? You're constantly inducing vomiting, so knuckles पे hyperpigmentation हो जाता है. Wonderful. So knuckles से ये दो चीजें याद रखो. Okay. और है बट अभी रहने देती हूँ. What is this? When you have periungual telangiectasia. So this is again something which is very specific for dermatomyositis, right? And this is shawl sign. This is shawl sign. Remember, mechanic hands is different. Mechanic hands is when you have hands जिसके पास ना बहुत सारे very roughened sort of hands. So that is now a different syndrome which is anti-synthetase syndrome. Okay, so these are all dermatomyositis. Uska ek subgroup ban gaya which is anti-synthetase syndrome, which will have ILD, which will have fever, which will have mechanic hands, right? Yeah, this was sent there in one more. So this is mechanic hands. So this is your anti-synthetase syndrome. ये मैं rheumat में पढ़ा दूंगी. I'll teach you in rheumat. Fine. So this is dermatomyositis. This has come in recent exam only, right? कि DM का DM के बारे में. Just one table from UWorld. So just systemic association. So acanthosis nigricans can be seen with insulin resistant diabetes, PCOD, GI malignancy. Multiple skin tags can also be a feature of insulin resistance, pregnancy, Crohn's, not very important. जो important है वो star लगा देती हूँ. Hep C and its associations, very very important. Porphyria cutaneous tarda, cryoglobulinemia, right? So PCT, cryoglobulin. One more thing which we studied yesterday, lichen planus, जो इन्होंने भी ऐड नहीं करा. And Hep B is pan. ठीक है, Hep B is pan. Dermatitis we already know. HIV, very important. It can have disseminated molluscum contagiosum. This question has come a lot of times in USMLE. They can have recurrent herpes zoster. They can also have severe psoriasis. So this is also something that you want to remember. Again, severe seborrheic dermatitis can also be a feature of HIV. This is also important. Multiple seborrheic keratosis, GI malignancy, we already know, sign of lesser Trilat. And erythema nodosum, pyoderma gangrenosum, both of them can be seen with IBD. ठीक है, तो बस इतना याद रख लो. Yes, even Norwegian scabies with HIV, है ना? यही बोलना चाह रहे थे ना? Yes, I remember that. चलो फटाफट previous year questions कर ले. चलो क्या है बताओ? Just read this. At birth, the child was found to be wrapped in membrane. So before you mark X-linked, because you are seeing trunk pe lesions, this is a mistake you could have made. But when you read this, child was found to be wrapped in membrane, this is lamellar ichthyosis. Got it? Very good. 30 years with flaccid bulla, crusting, suprabasal split. P. vulgaris. अगर subcorneal split बोलते तो सबकॉर्नियल बोलते तो P. foliaceus, right? ठीक है, ये ऐसे क्वेश्चन था रैंडम. preservative, it's a preservative, okay, methyl isoth or whatever. ठीक है, see again same image which I told you, this had come in AIMS also and FMG also last time. Oral ulcers है, flaccid blisters है, easy, pemphigus vulgaris. Investigation of choice for allergic contact dermatitis, patch test, right? Patch test. कुछ नहीं कर सकते. You have to keep Shraddha, right? You can't answer everything. Do you need to answer everything to get rank 1 in exam? Rank 1 gets 200 out of 200. No. So if you have seen all the questions of the last 2 years, wait, more important than answer here, guys. More important than answer is when you look at all the previous year questions of last year, we have covered 95%. So even if you aim for 95% and you end up doing 90% of dermat also, you end up doing 80% of dermat, your questions are going to come from this, from the 2 classes that we have done. एक ऐसा सवाल आ जाएगा random which you are not able to answer. Do you think that takes away rank? No. If you get this wrong, अगर एग्जाम में इसको गलत किया ना, your rank will go. But if you answer this correctly or you answer this wrongly, your rank will not be affected. समझ रहे हो? So in the exam you have to get questions correct which nobody will get wrong. You don't have to answer questions which nobody will get correct. You get that point? That is the most important thing. कि फोमो में अगर जियोगे ना कि यार कोई एक बंदा है जो पढ़ रहा है कि मिथाइल आइसोथायाजोलिनोन क्या है, and because this question came, one person is studying all the possible preservatives in all cosmetics, they are studying all humectant, surfactant, emulsifier. Do you think he will get a rank? No. In this process, if you forget कि pemphigus foliaceus क्या था, vulgaris क्या था, and BP क्या था, then your rank is gone, even if you remember this. Alright, so the key is to know the must know things and do questions correct जो कोई गलत नहीं कर रहा. Got it? ठीक है, तो ये फोमो से ऊपर उठोगे तो आगे जीत है. ठीक है, ठीक है. So this is about chikungunya. This is a chick sign. Alright? Okay. Patient with multiple blisters. Blister was located in the subepidermal region with neutrophilic infiltration. What is the treatment? So neutrophilic infiltration, right? So this can't be bullous pemphigoid. This is dapsone, है ना? Neutrophilic microabscesses. ये तो हमारे कल के summary से हो जाता. So this is what diagnosis? Neutrophilic microabscesses, dermatitis herpetiformis, picket fans pattern, है ना? Cool. 11-year-old boy, plaques over neck, cubital and popliteal fossa. See this very typical flexor distribution. This is atopic dermatitis. Perfect, guys. Are you getting confidence कि जो पढ़ा है उससे सब कुछ आंसर हो रहा है? ये क्या है? Pemphigus vulgaris, no? Brick wall. Row of tombstone appearance. 7-year-old child, 70-year-old patient with pearly raised borders, very easy, basal cell carcinoma. This is favorite of examiners for some reason. Following malignancy least associated with lymphatic. Again, in the exam, if you don't know, mark basal cell. ये भी एक trick है. Female with rash on exposure to sun after exercise. When she gets angry or eating spicy. See, so again, such questions will come. कि कभी भी उसने exercise किया, sun में गई, एंग्री हुई या स्पाइसी फूड खाया, एनी टाइम हर कोलिनर्जिक सिस्टम वाज गेटिंग एक्टिवेटेड, जब भी वो स्वेट कर रही थी शी वाज हैविंग रैश, राइट? सो दिस कैन अगेन बी सॉल्व्ड वेरी लॉजिकली, दे आर ओनली टेलिंग. तो खाली सन नहीं देखना, आफ्टर एक्सरसाइज स्पाइसी फूड तो सोलर केराटोसिस कांट बी देयर, राइट? सो दैट इज व्हाई कोलिनर्जिक. पैच टेस्ट इज रेड आफ्टर 48 and 96 hours. सीमेंट में क्या था? पोटेशियम डाइक्रोमेट, राइट? क्रोमियम, ठीक है, सी फॉर क्रोमियम. ये अगेन वेरी इंपॉर्टेंट, ड्रग फ्लैजिलेट पिगमेंटेशन, ऐसा फ्लैजिला जैसा मिलेगा. दिस इज ब्लियोमाइसिन. व्हाट आर अदर ड्रग्स व्हिच यू नो व्हिच कैन कॉज पिगमेंटेशन? amiodarone can cause bluish pigmentation, bleomycin can cause flagellate pigmentation. What else पढ़ाया था? Clofazimine, very nice. Clofazimine can cause ichthyosis and pigmentation. Rifampicin also. ठीक है, ये मुझे ये तीन ही बताने थे. These have come as exam questions. Okay, ठीक है, ये बोलो फटाफट फटाफट. My time is up. Last 2 slides are there. Same, no? Atopic dermatitis. Okay. 18-year-old with hypopigmented patch on medial aspect foot with, I'm also reading these questions for the first time only. Hypopigment, so vitiligo hai, right? Vitiligo mein kya use nahi karna? Isotretinoin. This person doesn't have acne. So we can use clobetasol, we can use topical tacrolimus, we can do PUVA. So treatment of vitiligo ho gaya. This is how it has been asked. So topical tacrolimus, topical steroids, systemic steroids is severe, and PUVA with soralin. ठीक है, तो साथ में हो गया अपना विटिलाइगो ट्रीटमेंट. एनसीसी था जनरलाइज पीलिंग ऑफ स्किन ऑल ओवर एक्सेप्ट पाम्स एंड सोल्स आफ्टर एंटी एपिलेप्टिक. सो अब बताओ डायग्नोसिस. गुड. सो ऑल ओवर है, राइट? सो विल इट बी एसजीएस और विल इट बी 10? सी दिस जनरलाइज पीलिंग. सो सिली मिस्टेक किया 10, राइट? सो एसजीएस 10. डायग्नोसिस पता था बट मिस्टेक हो गया ना. सो दीज आर द मिस्टेक्स यू हैव टू अवॉइड. अगर ये एग्जाम में गलत हो गया तो दिस विल कॉस्ट योर रैंक. Understanding? So this is what you have to see. Options ध्यान से पढ़ने. Obviously I'm not giving you a lot of time, but still you have to be efficient. Above question explained. So this person was likely taking, so this is vitiligo. Okay, so hypopigmented patch with feathery margins, rest of it is normal. So the option only basically tell you कि likely diagnosis क्या है, like that. Okay, ये क्या है? fishnet pattern है. Except, all except. So DSG3 हो सकता है, 1 हो सकता है, ये हो सकता है. So hemidesmosomes would be linear, right, at the subepidermal junction. बस हो गया. So we've done last 5 years के repeat questions of derma. We've finished complete derma, which I think is a feat in 3 hours, right? So I mean, kudos to you guys also that you could keep up with the pace, and kudos to me also because we finished this in entire subject in 3 hours. Hopefully we can do the same for short subjects. So we've done PYQs also. ये एफएमजी के लिए भी है, राइट? अलग से स्टार्ट क्यों करूं, सब कुछ हो रहा है यहाँ पे कवर. ओके, सो नाउ योर जॉब इज व्हाट. आज क्या करने वाले हो? सिंड्रोम्स, ठीक है? सो यू विल डू सिंड्रोम्स एंड बस दैट्स इट. देन यू विल स्लीप दैट यू हैव फिनिश्ड डर्मा. रिवाइज करो, इसी को रिवाइज करते रहो और सब कुछ हो जाएगा. कल नेक्स्ट क्लास इज टुमारो. Tomorrow our target is PEDS. So tomorrow we'll be doing general PEDS, so developmental milestones, growth, malnutrition, and we'll be doing neonatology. So that is our target for tomorrow, and day after tomorrow in PEDS we will be doing systemic PEDS. ठीक है? लेप्रेसी का आइडेंटिफिकेशन डिफिकल्ट लग रहा है ना, तो अगर एग्जाम में क्वेश्चन आया तो मार्क बीबी, बॉर्डर लाइन. द ओनली थिंग यू हैव टू सी इज क्या सैटेलाइट नोड्यूल्स है. सैटेलाइट नोड्यूल्स है तो बीटी है, अगर नहीं आता तो मारो बीबी. ठीक है, ये है आंसर. ऑलराइट, सो दिस इज फॉर लेप्रेसी. और एक्चुअली यही ऐसे ही है, एक बार या तो सैटेलाइट पूछा गया है, हम वरना हमेशा बीबी ही पूछते हैं. सो इफ यू हैव डन योर रिसर्च, दिस इज हाउ यू हैव टू क्रैक एग्जाम्स. ठीक है, पढ़ाई एक तरफ है, बाकी एग्जाम कैसे क्रैक करना इज डिफरेंट. ओके, चलो बताएंगे बाद में. ऑलराइट, आई विल सी यू ऑल टुमारो. बाय बाय.